So thank you for the invitation on medical marijuana. I will give a brief overview and then talk about my research. I'm going to quote from the United Nations Office on Drugs and Crime, the executive summary, and they had in the 2022 World Report, they said cannabis, and quoting, of course, is the most widely used drug on earth. And the amount that's used has increased around the country, around the world for both recreation and for medicinal purposes. This shows the distribution by gender. Cannabis is right here. And you can see in every case that is listed, males are more predominant. In terms of serious harm, tobacco is way up, and my position has been for years that tobacco should be eliminated, certainly in the United States. There's no therapeutic benefit. The only thing it does is cause toxicity, but it's way above some of the other drugs. I'm not saying that this is all good. I'm just looking at the relative comparison as the United Nations put out. Again, that was their summary. So in the United States, obviously, we have a serious problem. I'm sure everybody understands that. The death rate has continued to climb from overdoses, mostly from opioids. And in this slide, it's a little busy slide, but basically gabapentin in all the areas that are light blue, gabapentin has been added to the opioids. So it's not just the opioids alone. So we have marijuana. And this was the situation about 20 years ago. It's a single plant. There was not a lot of research going on in marijuana. One of the things that's interesting is if you look at this slide at the very bottom, it talks about some of the conditions, and this is several years old, some of the conditions for which individuals use marijuana. You see multiple sclerosis, nausea and vomiting from chemo, PTSD. But chronic pain by far outweighs it. And again, this is a few years old, but it's still prevalent today. Chronic pain is the highest use. The National Institute on Drug Abuse, where I reside, talks about a number of things. For example, addiction. Can you really be addicted to video games? Yes. And the World Health Organization finally did acknowledge that. In terms of the United States, again, this is from our organization. The majority of people who use marijuana do not, and that's scientists, do not go on to use harder drugs. In other words, it's not simply, well, somebody smokes a joint and tomorrow they're shooting heroin. That's not the way it works. NIDA says that alcohol, this is NIDA, National Institute on Drug Abuse, and nicotine also get the brain ready for other drugs. Like marijuana, they're used before. So alcohol, nicotine, as well as marijuana, are used before a person goes on to harder drugs. In addition, a person's social environment. Who are their friends? What is their peer group? What about their parents? We all know that if one or both parents are drug abusers, their children will also be. So that's the bottom line. It's not just marijuana, it's any of these compounds used before can likely propel a person into using harder drugs. Plus, as you can see in the slide, social interactions. So addiction, it's a psychological condition. It's very serious. People get addicted to a number of things. You can see that on the slide. And including on the right side, tanning. People get addicted to that. That's what we know. Video games, sex, and drugs. So it's a serious problem. Serious psychological condition. In my area of pain management, opioids, if we give them to a normal patient, does not convert a normal patient into a drug-seeking addict. Patients who are in serious trouble in terms of pain do not move to addiction. So physical dependence is the issue, the biologic condition. Most of you know this. You're get used to having a drug every day. Caffeine, after a while, if you drink a cup a day, you may need 2 cups and then you progress. So this is an adaptation by the system. The same thing happens with opioids or narcotics in a normal patient, particularly in a cancer patient if the disease progresses. I created the term suicidogen based on my work with cancer patients And in my world, anything that causes any factor, situation, or condition that causes a person to want to commit suicide is a suicidogen. And again, in my world, poor pain management is a suicidogen. I've experienced that. I've seen that directly with some of my patients. In terms of yearly deaths in the United States, but again, going back to it, we have over 500,000 deaths from tobacco. Opioids, now it's over 100,000. Marijuana, 0. Why is that? What's the cause of that, particularly for opioids? Well, opioids depress the brainstem respiratory center. That's the cause of death, respiratory depression. Marijuana does not affect the brainstem respiratory center. So therefore, there really, as far as anybody knows, no deaths due to just an overdose. Now, if you're driving a car and you're on marijuana and you have an accident, that's a different story. But by itself, marijuana doesn't do this. So cannabis has been around for thousands of years. There's sativa, there's indica. And in terms of THC levels, sativa has the higher THC level, indica has higher CBD, and there are many, many hybrids. In terms of output, the female plant has higher THC than the male plants. There's hash oil. This is just a quick review from the plant. That's the oil. It's about 15 to 30% THC. Resin is dried to make hash. Second strongest, about 10 to 20%. And the lowest level, the dry buds and leaves, and that's in fact what most commonly is known as marijuana. There's a lot of cannabinoids in there, cannabidiol, CBD, which we know, delta-9 THC, and in the United States now we have delta-8. The laws in the United States really are against delta-9 at the federal level. At the state level, of course, as many of you know, it is legal. Delta-8 is in there. It is basically the same clinical profile as delta-9, except it is less powerful. But this now is being sold in the US because the law does not ban delta-8. From a molecular standpoint, CBD, THC, quite similar. This is for folks with an organic background. So there's really not much of a difference from this standpoint. But again, as we know, THC has a psychological highs. CBD basically does not. In terms of the brain, anandamide is the chemical, just like endorphins, which were found by Terranius in 1978. THC, the molecule, is very similar to anandamide. So THC fits on those same receptors, just like narcotics, opioids fit on the endorphin receptors. Acetylcholine, serotonin, and dopamine are the neurotransmitters. And we know where the systems are, serotonin pathways, dopamine pathways. This is nothing new, but these are what are affected by THC. And again, this is the comparison, THC, the molecule, and anandamide. So a number of things that this triggers: memory, movement, hunger, and pain. Where are they? CB1 receptors are mostly in the central nervous system. CB2 are mostly in the periphery. The mechanism of action is pretty well known. It can get quite detailed, but basically I'll just scan through some of this. In the presynaptic area, then we have the release of neurotransmitter. We all know this. In terms of the endogenous cannabinoid, it's retrograde, which means it's now going back to the presynaptic area. That's activated. In this particular example, it's a G protein, which reduces neurotransmitter release. And then you have cannabinoid therapy, which occurs. Nabilone is one of these products. In the United States, it is a synthetic compound. What does it do? A lot of things, but the initial start was because of the euphoria reward system, mostly hitting dopamine. This slide, again, is busy, but I just used to show you that there was a lot of research going on lipostatic activity, anti-proliferative, anti-inflammatory, anti-pathogenic. So again, it's a busy slide. I'm just showing you that the research now is gaining strength in terms of the number of studies that are going on to try and figure out what it really does. Where does it hit? The cortex, the higher cognitive function, hypothalamus with appetite, hippocampus, learning and memory, peripheral sensations, including pain, the basal ganglion cerebellum, movement issues, and the medulla, nausea, and vomiting. Again, a busy slide, but I'm just showing you that these are all the different effects that the endocannabinoid system can affect. So this is a really unusual molecule, more unusual than anything that's been uncovered other than just a neurotransmitter like acetylcholine, which acts all over the body, or norepinephrine and epinephrine. This is kind of interesting. You can't spell healthcare without THC, and there's THC, and there it is in the middle. So in the where I live in Pennsylvania in the United States, they have prohibitions on blood levels, and the blood level is 10 nanograms per mil. So if somebody has that in the state of Pennsylvania, where I am, they cannot operate a car or be in charge of anything that is hazardous. Now, again, most of you know this, but the high perfusion area tissues, which is the brain, the drug is going to get there, THC is going to get there quicker. Low perfusion, like the fat, it's going to be a slower entrance, and it's going to be a slower buildup. In terms of peak effects, again, this is smoking, gets up pretty quick, within minutes, basically. This is oral, which takes time, hours. Now, showing you, this is a cigarette with 3.55% THC, and showing you this is, again, the limit in my state, Pennsylvania, 10 nanograms per mil, but smoking this 3.55% gets you 15 times above that within about 10 minutes. This is by Dr. Lynch. She did a very good study, and what she showed was there was a good correlation of the blood THC in nanograms per mil versus the blood in picograms per liter. So the point of this study was, yes, it's possible now to measure blood levels and get a good estimate from just using a breath level. This is chronic users. This is a very old paper, but as I tell my medical students, if it's old but has valuable data, it's useful. So this is basically showing how long it takes for chronic users, how long it takes for the THC to get out. And in this very well done study, it took 46 consecutive days when they still were over 20 nanograms per mil in the urine, 77 days below the cutoff. So if it's a chronic user, there's a lot of THC stored in the fatty tissue, and it's slowly going to be leached out. Impairment, okay, motor coordination, short-term memory, judgment. This is a study that was done on driving performance and clearly indicated that there is a negative effect on driving. They did placebo-controlled smoking cannabis by regular users, simulated driving decrements. Not a good idea to drive, and they used a 5.9% or 13.4% THC product. The other thing that was brought out was that in some of the products that are available, they're not, the doses aren't very good. The dose levels often misrepresent what's in there. And so trying to figure out what's going on with cannabis is complex. Here it is. Many of these are over-labeled, some are under-labeled. Exacerbation of schizophrenia, that we know that can happen. If somebody has it, it can exacerbate, but in large doses, anybody can have psychosis. Chronic effects, there is addiction, of course, and tolerance, hyperemesis. A young patient coming into the ER with really serious nausea and vomiting, they're going to ask them about any potential marijuana use. There doesn't seem to be any significant cause with lower IQs, amotivational syndrome, decreased achievement. I mean, none of these are proven with marijuana. Prenatal, again, very clear. cannabis use during pregnancy should be discouraged, because what they showed was that the offspring have thought and social problems, sleep problems, body mass index, as well as lower cognition and gray matter volume. Vaping is also a serious issue, and in the United States, it was found that vitamin E is in the product. They had bronchial pneumonia. It caused fatalities, and vitamin E seemed to be the causative factor in the vaping. So as medicine, as I mentioned before, in the U.S., cannabidiol is available for seizures. Delta-9 THC is available for chemotherapy, nausea and vomiting, and anorexia, and there are 2 products. Last, getting into my study on chronic pain, it's involved with a lot of factors. These are my colleagues, Dr. Lucia Dio, Jen Smith, a nurse, Dr. Lubick at DO, my medical student, Matty Brown. I presented this 20 years ago at the American College of Clinical Pharmacology. And inclusion 25 to 75, neuropathic pain for 2 or more months. They're on analgesic medications. They can understand consent form. We rule out cardiovascular conditions, substance use disorder, use of antidepressants, and pregnancy. I record 0, no pain, up to 10, the worst pain I ever had for the patient. How many meds are they taking per day? I don't tell them to stop it. They can take it as we begin. For the first 2 weeks, it's baseline. They're taking anything. They're recording pain scores for 2 weeks. Then if they're ready to go and they sign the consent form before we start. Then we start with up titration, 5 milligrams at bedtime. And I see them every week. How's it going? If they're fine, we up titrate to 10 milligrams the next week, then 15, and then 20. In this case, these are a number of my patients. Many of them have had a reduction in what they're using. Gabapentin in this patient had a reduction. Another patient, 0. They were using over 1,400 milligrams of gabapentin, and after 4 weeks, they were 0 gabapentin. This patient sort of a wash. There was a drop in gabapentin by 75%, an increase in Tylenol by about the same amount. But as we all know, gabapentin is much stronger than Tylenol. So this was also beneficial. Patient number 5, slight increase in gabapentin, slight increase in ibuprofen, not too much. But patient 6 had a very significant drop in carbamazepine, sorry about that, to 0, and that's used for serious nerve pain. Diclofenac is an aspirin-type compound, a slight increase. This last patient, not too much slight increase. So overall, so there was a reduction in overall analgesic use, not in every patient, as I showed you. My patients are asking about change in body weight. 2 of the patients did have a slight increase, but the other 5 had actually a decrease. Now, this is not a strong, significant amount, but the point is that it didn't go down in the majority of my patients in this pilot study. Why? Well, we think because there's less anxious. I know that. They slept better. I know that. They probably needed less comfort food, and they probably can walk around more. So it's not automatic that if you get into a study with THC, you're going to gain weight. And the last, the control over weeks 1 and 2 on a scale of 0 to 10 is close to 5. 4.9 is their pain scale. After the end of the study, they were down to 2.7. That's a drop of more than 2 units, which in my world of clinical pharmacology and pain management, that's a significant level. So administration of THC, PO at night for 4 weeks did produce a decrease in pain scores and reduction overall in use of analgesic medications. So where marijuana was initially kind of small 20 years ago, not much research, now it's robust, tremendous amount of research going on for this drug that is very, very useful. It's safe. There are side effects, as I showed you, but I would rather have a patient on this drug than opioids for pain management. So again, I thank the group for inviting me. They're going to put on the chat my email, so you can certainly send me an email, and I will be happy to answer it.